Please, good evening. Kindly, please, can you hear me? Please, can you hear me? Please, kindly confirm if you can hear me before we start, please. I think we can unmute ourselves if we want to raise a question or if we want to contribute. Okay. Please, can you hear me?
Yes, we can.
Okay, thank you very much. So please, you are welcome to Achievers NCLEX-RN review. So basically, we call this Achievers Friday. It's a free NCLEX review, and we plan to do this every Friday. So we pick a topic, we discuss it in details, all the key NCLEX points on that very topic. Not just that, after looking at that very topic in details, we pull questions from different skill banks and we share the link on the Telegram platform so that at least you take an assessment of the subject or the topic that we discuss. We believe in this sense, it would help us in terms of the areas that we should master, especially from the skill banks and the areas that we should know for the NCLEX. So before we move on, I would like to do a small introduction. My name is Haja Fati, and I am the team lead of Achievers NCLEX-RN Consult. With me are my team members, RN Lily, RN Abba, and RN Adoma. Yes, I believe we are all here. So basically, just something brief about our consults. I believe you can see the screen. We've shared the screen with us. So we are a consult, and these are some of the services that, please kindly mute yourself. So these are some of the services that we render. NCLEX-RN assessment, that is a readiness assessment. I think I need to off. Sorry, please kindly mute yourself if you are not talking, please. So in terms of the English registration, tuition, we offer a 4-month intensive tuition. Anything NCLEX, you can link up with us on our website, or you can send us a message. You can email us at info@achieversnclassrn.com and we will attend to you. So that is something brief about our consult. So basically, with our 4-month tuition, the next cohort is scheduled to start on the 4th of March this year. So that will be going next week. So with our tuition, we do a 4-month intensive tuition. We go through all the key NCLEX points, all the topics that we have to study for the NCLEX. Not just that, for every topic that we discuss, we put questions from different skill banks. So for instance, if you talk about asthma, COPD, pneumonia per session, we put questions in the form of assessment and we answer them individually. So once you answer them, you get your scores, you're able to do the remediation and you're able to also make notes as well. So we believe learning in this style or learning in this manner actually help us to build content, because at Achievers, we believe that NCLEX is all about content building, content mastery. Even though there may be some strategies that you may use or you may apply to answer questions, but we believe that NCLEX is 99% content. If your content is very sharp, trust me, the NCLEX is not going to be so difficult. And that is what we do. We go through everything, all the topics within the 4 months. And after the 4 months, we do readiness assessments. Depending on your timeline, you can book the exam and you write. So basically, we give you all the resources. We give you all the key points that you need to get to nail the NCLEX once. So one of our greatest achievements is that most of our nurses do nail the NCLEX at 85. Most of our candidates nail the NCLEX at 85 because we build strong content in our tuition. So please, do not spend much time. I think our numbers, we are quite okay to go. I believe in the course of the meeting, the others would be able to join us. So the March cohort will be starting very soon. So if you want to be a part of the cohort, you can send us a DM or you can write to us on our website. There is a contact us link on our website. So once you link with us, we'll be able to add you to our tuition, and it's 400 cedis a month, 400 Ghana cedis a month. So if you have to do the conversion into US dollars, it's 32 US dollars. So with that, I think you can do the conversion depending on the country that you are in. Yeah, so please fast forward. We want to do a review, a short review today. And please, what topic are we looking at today, RNs? What topic are we looking at today? Please, anyone?
Fallot tetralogy or?
Please, which topic are we looking at today, please, RNs? The topic that we are looking at today.
Is it not Fallot?
Tetralogy of Fallot.
Exactly. So today we want to look at the Tetralogy of Fallot. The Tetralogy of Fallot. And trust me, at the end of this discussion, we shouldn't get questions on Tetralogy of Fallot. So in the course of the meeting, we'll be using the shorthand TOF. TOF. So TOF, the same as the Tetralogy of Fallot. Sorry, please kindly mute yourself. So today's review, we are looking at tetralogy. The Tetralogy of Fallot. That is what we are coming to. So we are looking at the Tetralogy of Fallot, the Tetralogy of Fallot. And those of us who have been through the various skill banks, there are quite a number of questions on Tetralogy of Fallot, and these questions are not so much difficult to answer. So we want to begin with our review. So Tetralogy of Fallot, it is a congenital heart defect. So the key point, the key thing that we would build on is the fact that it's a congenital heart defect. A congenital heart defect. So the Tetralogy of Fallot centers around the heart. So it centers around the heart. So before we delve in, I want us to build a foundation very, 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 very well. So let's have a look at the structure of the heart. So you should be able to understand the structure of the heart and also how blood flows through the heart. It's very, very much important to this very discussion. So I want us to have a look at this image. Please, can we see the image on the white screen? The image of the heart. Please, can we see the image of the heart on the white screen? Okay, so I think I have muted all of us. So please, we can chat in the box or we can chat on a Telegram platform. Okay, yes. So I believe you can all see the image on the screen. We need to understand the circulatory system of the heart. And when we talk about the circulatory system of the heart, we just want to talk about how the blood flows through one chamber of the heart to another chamber till it gets to the systemic circulation. So that is what we want to look at. So the circulation system of the heart is very, very, very simple. So let's have a look at this very short animation, and we'll build up on the animation, and we would then progress. So kindly confirm if you can see this short animation, please. A very short animation. I think it's a 2 minutes animation of the circulatory system of the heart. Please, can we see the short animation with the audio as well?
The pathway of blood flows through. Oxygen pour blood from your body returns to the right atrium.
Please, can we see the video?
Blood from your upper body returns through the superior vena cava.
Okay.
Blood from the lower body returns to the inferior. The pathway of blood flows through the heart. Oxygen pour blood from your body returns to the right atrium of the heart. Blood from your upper body returns through the superior vena. Blood from the lower body returns through the inferior vena cava. As the right atrium cracks, the tricuspid valve opens and blood is of your heart. When the right ventricle is full, the tricuspid prevents blood flowing back into the atrium. The right ventricle to the contracts, pulmonary valve opens, and blood is pumped into the pulmonary artery and to your lungs. The pulmonary valve closes to prevent blood from flowing back into the ventricle. Oxygen-rich blood from the lungs returns to the left atrium of the heart. As the left atrium is filled with blood, it contracts, the mitral valve opens, and blood is pumped into the left ventricle of your heart. This occurs at the same time as the right atrium pumps blood into the right ventricle on the other side of the heart. As the left ventricle is full, the mitral valve closes, the aortic valve opens, the left ventricle contracts, and oxygen-rich blood is pumped into the aorta to reach all parts of your body. This happens at the same time as the right ventricle pumps blood into the pulmonary artery on the other side of the heart. The aortic valve quickly closes to prevent blood from flowing back to the heart. Meanwhile, the atria have filled with blood, and the cycle repeats itself.
Okay. Please, I believe we saw the short animation of the circulation system of the heart. So let's go back to our whiteboard. So from the animation that we just saw, I believe we picked up some key things from the animation. So basically, the blood from the top part of our body would come through the superior vena cava, so superior up. The blood from beneath or below the body will come from the inferior vena cava. So basically, the blood from the inferior vena cava and the superior vena cava would fill the right atrium. So this is the right atrium. Once the blood fills the right atrium, that is, the right atrium would relax. That is during diastole. Diastole means what? Relaxation. So once the right atrium is filled with the blood, now the tricuspid valve would then open up. This is the tricuspid valve. I believe you can see the tricuspid valve where I'm shading, where I have circled. So that is the tricuspid valve. So the tricuspid valve would then open up. Once the tricuspid valve opens up, the blood will fill the right ventricle. So this is the right ventricle. So once the blood fills the right ventricle, now the right ventricle, after relaxation or after the diastole, will then contract. It needs to push the blood through the pulmonary artery. And please, with the images of the heart that we see, you realize that one aspect has been shaded as blue, and the other aspect has also been shaded. So the left aspect has been shaded as what? As a red, and the right side has been shaded as blue. The blue represents what? The deoxygenated blood. So the red aspect to the left indicates what? Oxygenated blood. So over here, the blood has filled. Please kindly mute yourself. Muting and talking is a great deal of work. So the blood will fill the right ventricle. The right ventricle has to squeeze the blood. So to squeeze the blood or to shunt the blood through the pulmonary artery. So this is the main pulmonary artery. So please, let's take note. The pulmonary artery is the only artery in the body that carries deoxygenated blood. We are very much aware that arteries carry what? Oxygenated blood. But there's an exception. So this only the pulmonary artery that carries deoxygenated blood. So the blood from the right ventricle would move through the pulmonary artery after the pulmonary valve has opened up. From the pulmonary artery, where is the blood going? The name of the artery rings a bell, pulmonary. So which organ do we think of, please? Please, which organ comes to mind? From the pulmonary artery, it gets to which organ? Please, which organ comes to mind? Yes, so yes, Aaron Joe says the lungs. Yes, Aaron, you are very right. The blood is going to the pulmonary circulation, the lungs, the pulmonary circulation. And why is the blood getting to the pulmonary circulation? It gets into the pulmonary circulation for what? For oxygen. So once the deoxygenated blood is now oxygenated, it needs to return to the left side of the heart. So the blood would return to the left side of the heart through the pulmonary vein. And of course, veins carries deoxygenated blood, aka blood without oxygen. But there is an exception. It is only the pulmonary vein that carries oxygenated blood. All veins carries deoxygenated blood, with the exception of what? The pulmonary vein. So now the blood is now rich in oxygen. It is returning back to the left side of the heart to pass through the pulmonary veins, and then the blood will get to the left atrium. Once the blood gets to the left atrium, the mitral valve, of course, will close and the blood will fill the left atrium. After filling the mitral valve, there's a mitral valve. The mitral valve would open up and the blood will move from the left atrium to the left ventricle. Please, what is the other name for the mitral valve? In case we see that in question, if we don't see mitral valve, please, what is the other name for mitral valve? All right, exactly, bicuspid. So the mitral valve is also called bicuspid valve. So please, let's take note of this. Very, very, very much important. So the mitral valve or the bicuspid valve would open up and the oxygenated blood will fill the left ventricle. Now you realize that when you look at the structure of the heart, the left side of the heart, in terms of the muscles, it has a thicker muscles as compared to the right side of the heart. And it's for a reason. Because the blood there is oxygenated, it needs to pump or it needs to contract so that it will squeeze the blood through the aorta. So the muscle there is thicker for that reason. It has to pump at a higher pressure so that it will push the blood through the aorta. So now the blood that is rich in oxygen at the left ventricle will then move through the aorta after the aortic valve has opened up. So right from the aorta, then the oxygenated blood will get to the rest of the body to get to the systemic circulation. So you realize that the circulatory system of the heart is not so difficult. We need to know which chamber would the blood come first and which valves would open. So understanding the circulatory system is very, 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 very much important in our discussion. So we are looking at the Tetralogy of Fallot. That is why we are looking at the circulatory system of the heart, which is very much important, as we've said earlier. So basically, Tetralogy of Fallot is a cyanotic heart defect. That is another key NCLEX point. It's a cyanotic heart defect. Tetralogy of Fallot. It is a cyanotic heart defect. So the name rings a bell, cyanotic. So we can pick the word cyanosis. So an individual would experience cyanosis when they're having hypoxia, which means that they're having a decreased amount of oxygen in the blood. So the skin will turn bluish, cyanosis. So Tetralogy of Fallot is a cyanotic heart defect. So kids that are afflicted or that's who suffers from the Tetralogy of Fallot, they usually become blue or gray, their skin. So that is termed as what? The cyanosis. So as we proceed, we would appreciate why the Tetralogy of Fallot is a cyanotic heart defect. So please, I should say this. We have cyanotic heart defects. There are some defects of the heart that can cause cyanosis. And likewise, there are some defects of the heart that will not result in cyanosis. So please, let's take some few minutes and clarify or to delve into this more. So we have cyanotic heart defects. So the cyanotic heart defects, what we want to say is that they are those defects that decreases the oxygen level in the body. The defect that decreases the oxygen, the amount of oxygen in the blood. Definitely, if you have less oxygen in the blood, it is going to result in less oxygen supply to the tissue. So what we want to say is that hypoxia, less oxygen in the blood, can lead to hypoxemia, different things. Hypoxemia, less supply of oxygen to the various tissues. So with the cyanotic heart defect, we are having less oxygen level in the blood. So we can say that less oxygen or a decreased oxygen in the body. So with the cyanotic heart defect, these defects decreases. It decreases the blood flow. We're having a decrease of blood flow to the lungs. Blood flow to the lungs. So the cyanotic heart defect, that is what happens. We have a decreased blood flow to the heart. To the lungs. If you're having a decreased blood flow to the lungs, what would happen? From the circulatory system that we just saw, the blood will move from the right ventricle through the pulmonary artery to get to the pulmonary circulation for oxygen. So if in these cyanotic defects, you're having less of this blood getting to the lungs, it means that you're going to have less blood that would receive oxygen. And then the net effect is going to lead to a corresponding what? Cyanosis. So that is for the cyanotic heart defect. And one of the cyanotic heart defects is the Tetralogy of Fallot. Tetralogy of Fallot. In fact, there are 5 common cyanotic heart defects. And Tetralogy of Fallot is one. Tetralogy of Fallot is one of the cyanotic heart defects. So please, we should be able to differentiate between the cyanotic heart defect and that of the acyanotic heart defect or the non-cyanotic heart defect. Absent, right? Acyanotic, no cyanosis. So Tetralogy of Fallot is one of the common cyanotic heart defects. Of course, we can also talk about our, what we call the tricuspid atresia. Tricuspid atresia. So tricuspid atresia, even though we are not looking at it, we are looking at the cyanotic heart defect, of which the Tetralogy of Fallot is one of those. So we want to look at those conditions or those defects. Tricuspid atresia is also considered as a cyanotic heart defect. We know the tricuspid valve, and we know what is referred to as atresia. So in tricuspid atresia, what happens is that the tricuspid valve fails to form. Please, can you hear me? Please, can you hear me? Hello? Please, can you hear me? Okay, sure. So in tricuspid atresia, we are saying that it is also an example of a cyanotic heart defect. It is a congenital heart defect as well. The tricuspid valve will not form very well. And we know where the tricuspid valve is. So instead of the valve to form, we'll have a solid sheet of tissue that will block the flow of blood between the right side of the heart, the 2 chambers, the right atrium and that of the right ventricle. So tricuspid atresia can lead to cyanosis, and it is one of the cyanotic heart defects, tricuspid atresia. We are saying that there are 5 common cyanotic heart defects. So that is the second one. And we can also have a condition that we call the truncus arteriosum. The truncus arteriosus, the truncus arteriosus. The truncus arteriosus is also a cyanotic heart defect. So basically, the truncus arteriosus, what happens is that we have a mix of the oxygenated blood and that of the deoxygenated blood, the truncus arteriosus. We're having a mix of the oxygenated blood and that of the mix of the deoxygenated blood as well. Let me try and get an image of the truncus arteriosus so that we would appreciate what we are looking at, even though it's not what we are looking at, but we want to emphasize on the cyanotic heart defects, the acyanotic heart defects, and also to a lesser extent, you can also have the obstructive heart defects as well. So please, just some few seconds, let me get an image of the truncus arteriosus. Okay, but before then, let's have a look at this. I believe you can see this image. Let's have a look at this. Let's have a look at this image. This image, it also shows one of the congenital heart defects that belongs to the cyanotic heart defect. So this condition, we call this condition the transposition of the great arteries. Transposition of the great arteries. I'll get an image of the truncus arteriosus, but then it's basically once that happens, the defect will lead to a mix of the deoxygenated blood and the oxygenated blood that is entering the systemic circulation. Another of these defects is the transposition of the great arteries, The transposition of the great arteries is also one of the cyanotic heart defects. Transposition of the great arteries. We can see from this image what is happening. This is the structure of a typical heart. And this is the structure of a defective heart with the transposition of the great arteries. We sometimes call it the parallel circulation. We call it the parallel circulation. We are all seeing what is wrong here. This is the typical heart. This is the aorta. This is our left ventricle, this side, the left ventricle. From the left ventricle, the blood will then move through the aorta. But in the transposition of the great arteries, please, who can tell us what is wrong? You realize that the aorta and that of the pulmonary artery has swapped. There's a transpositioning. They've swapped. Instead of the aorta to be at its usual place, so the aorta should have been here, where I'm shading. But then the aorta will find itself at the area of where the pulmonary artery should be. So in other words, the pulmonary artery and the aorta has shifted position. They've shifted position. So that is what happens in the transposition of the great arteries. And when this defect is seen, or when it happens in a newborn, it can lead to cyanosis. So this is also considered as one of the cyanotic heart defects. So please, let's take note of this. There are 5 common cyanotic heart defects that we have to know. Tetralogy of Fallot, tricuspid atresia, truncus arteriosus, transposition of the great arteries. And the 5th one that we talk about is what we call the total anomalous. The total anomalous pulmonary, it has a very long name. Pulmonary venous return. So that is the 5th one, total anomalous pulmonary venous return. So sometimes it is abbreviated as TAPVR. Yes, it's the total anomalous pulmonary venous return. It's also one of the cyanotic heart defects, and it's very present in early infancy. Right. So when we have this condition, we're having oxygenated blood. Let's have the look at the structure of the heart. So let's consider the typical heart. In this condition, the total anomalous pulmonary venous return, we are not looking at it though, but we just want to have the overview of what happens in this condition that is considered as the cyanotic heart defect. In this very condition, what is happening is that the oxygenated blood that is flowing through the pulmonary vein, we saw the pulmonary vein, right? After the blood has found itself in the pulmonary circulation, if it has received oxygen, it will then return to the left side of the heart through the pulmonary vein, of course, which is the only vein that carries oxygenated blood. From the pulmonary vein in a normal heart, the blood should fill which chamber of the heart? RNs. From the pulmonary vein, the blood first fills which chamber of the heart, please? Which chamber of the heart is filled when the blood is moving from the pulmonary vein? Which chamber of the heart is filled first? I'm seeing right atrium, left atrium, left atrium. Is it the right atrium or the left atrium? All right. It is the left atrium, exactly, the left atrium. But in this very condition called the total anomalous pulmonary venous return, what happens is that instead of the blood that is oxygenated, that is flowing through the pulmonary vein, instead of it to enter the left atrium, what is happening is that the blood would enter the superior or the inferior vena cava, and the blood would get into the right atrium again. So you realize that over here we are having a mixture of oxygenated blood and the deoxygenated blood. So that is what happens in this condition. The blood that is flowing through the pulmonary veins, it enters the superior and the inferior vena cava as a result of the defects. Once the blood that is oxygenated finds itself again in the superior vena cava or the inferior vena cava, it's going to fill the right atrium. So there is a mixing of blood, and that can lead to cyanosis. So these are the 5 cyanotic heart defects that we should know. Tetralogy of Fallot, tricuspid atresia, truncus arteriosus, transposition of the great arteries, and the image is on the screen where the position of the aorta and that of the pulmonary artery swaps. And lastly, we have the total anomalous pulmonary venous return. So what we want to say is that Tetralogy of Fallot is an example of a cyanotic heart defect. And as we move on, we appreciate why it is a cyanotic heart defect. So as we said earlier, we can have another classification. There are some heart defects that will not lead to cyanosis. So those heart defects, we call them the acyanotic. The acyanotic defects, heart defects. A means absent, right? Or without, so without cyanosis. So with the acyanotic heart defect, what is happening is that, yes, the defect is there, but then it will rather be the opposite of the cyanotic heart defect. With the cyanotic heart defect, we are saying that we're going to have a decrease of oxygen in the blood because we are going to have a decreased blood flow to the lungs. If you have a decreased blood flow to the lungs, you are going to have definitely going to have a decrease in oxygen. But that is the opposite. In the acyanotic heart defect, we are rather having an increased blood flow to the heart. In the acyanotic defects, we are having an increased blood flow to the lungs, increased blood flow to the lungs. So that is what happens in the acyanotic defects. There is an increased blood flow to the lungs. So if you're having an increased blood flow to the lungs, definitely the blood that is gone to the lungs or that is gone to the systemic circulation would return back to the heart, to the left side. So in other words, we are going to have an increased return to the left side, and it is an increased return of what? Oxygenated blood. So these conditions would not lead to cyanosis because we are going to have an increase in the blood flow to the lungs. So because of that, we are not going to have cyanosis. So that is why those conditions are termed as the acyanotic heart defect, the acyanotic without cyanosis. We have adequate blood. We have adequate blood that is rich in oxygen, even though we have the abnormality. So we can have an examples of the acyanotic defects. We can talk about the patent ductus, the patent ductus arteriosus. So patent ductus arteriosus, usually it's the PDA. It's an example of an acyanotic defect, even though the defect is there, but it will not lead to cyanosis. Atrial septal defects, atrial septal defects is also an example of an acyanotic heart defect. Ventricular septal defects. So atrial septal defect, you can write ASD. Same as the ventricular septal defect, VSD. Ventricular septal defect is also considered as an acyanotic defect. So we should be able to differentiate between cyanotic heart defects and acyanotic heart defects. And the difference is very simple. Cyanotic heart defects will lead to cyanosis. Why would it lead to cyanosis? It will lead to cyanosis because in the cyanotic heart defect, we are having a decrease of blood that is getting to the lungs, that is getting to the pulmonary circulation. That is for the cyanotic heart defect. But for the acyanotic heart defect, even though the defect is there, but we are going to have an increased blood flow to the lungs, aka the pulmonary circulation. So in this instance, we are not going to have the cyanosis. And a classical example of the acyanotic defects are the patent ductus arteriosus, the atrial septal defects, and that of the ventricular septal defects. So we should be able to understand this classification. So what brought us here is the fact that we said the Tetralogy of Fallot is a cyanotic heart defect. So that is one of the key NCLEX points that we should take note of. Of course, in the previous points, we said that we can also have what we call the obstructive heart defects. By virtue of its name, obstructive heart defect means that the defect, we are going to have an obstruction. There's an obstruction somewhere, right? So that is where we can have the obstructive heart defect. A classical example in the various scale bands is the aortic stenosis. The aortic stenosis. Stenosis means what? We are having what? A narrowing. So if you're having a narrowing of the aorta, it means that it can cause a form of an obstruction. We can also think of what we call the coarctation. We call it the coarctation of the aorta. Coarctation of the aorta. Coarctation of the aorta is also an obstructive heart defect, where we are having a narrowing anywhere along the aortic tree. So the coarctation of the aorta, quite similar to the aortic stenosis. The coarctation of the aorta, same narrowing. We have narrowing along the tree of the aorta or along anywhere in terms of the length of the aorta. So coaptation of the aorta, aortic stenosis, of course, they can all cause an obstruction. We can also have the pulmonary valve stenosis. If the pulmonary valve becomes so stenosed, the pulmonary valve becomes so stenosed, narrowed, it will cause an obstruction, right? So please, let's, especially the cyanotic defect and also the acyanotic defect, we should be able to understand the difference between the two, and also, if possible, some of the some of the examples of such defects and what we've talked about. So, Aaron, we are going back to our Tetralogy of Fallot. So the key NCLEX point, one of the key NCLEX points that you said so far is the fact that it is a cyanotic heart defect. It is a cyanotic heart defect. So this is one of the key NCLEX points that you want to put across. So Tetralogy of Fallot, you can pick a key term from it, tetra. Please, what does this term mean? Tetra, what does it mean? Tetra, tetra. What comes to mind if you hear tetra? Tetra. So exactly. So tetra means 4. So it means 4. So what we want to say is that Tetralogy of Fallot, we have 4 structural distinct defects that makes up the Tetralogy of Fallot. Tetra means 4. So in Tetralogy of Fallot, we have 4 structural defects that can be seen in this very defect. And please, one of the common questions in the various skill bank is this question, the question that will be asked to pick a structural defect that falls under the Tetralogy of Fallot. So this is also one of the key NCLEX points or the key NCLEX areas. If not anything, know the 4 structural defects that form the Tetralogy of Fallot. So, Aaron, let's have a look at this image. Let's compare the normal heart to a heart that has the Tetralogy of Fallot so that we can pick the difference or the 4 structural defects, which is very, very, very much important. Please, can we see the image on the screen? Please, can we see the image on the screen? Please, can we see the image on the screen? Please, kindly confirm if you can see it. Okay, please. So let's consider the structure of the normal heart. And let's now consider the structure of the heart with the Tetralogy of Fallot. So, of course, the image has already spelled out the 4 defects. So we can compare it. So the 4 structural defects, 1, we are having, let's see, we are having the right ventricular hypertrophy, an enlargement of an organ. So we are having a right ventricular hypertrophy. You realize that this is the structure of the normal heart. When we consider the structure of the normal heart in terms of the thickness of the muscle wall of the right ventricle and that of the heart with the Tetralogy of Fallot, we will clearly appreciate the fact that the heart with the Tetralogy of Fallot, there is hypertrophy, there is an enlargement of the right ventricle, which should not be so. So one of the 4 structural defects in Tetralogy of Fallot, 1 is the right ventricular. So for short, right vent hypertrophy. So right ventricular hypertrophy, we are having an increase and growth in the muscle cell. So that is why side is very thicker than normal. And clearly from the image, another defect we see is the aorta displacement. Please, let's look at this image, the 2 images, this very, very, very clearly. We are having an aortic, please, let's take note of this. Aortic displacement is also called overriding aorta. So please, let's take note. So in a question, if you don't see, please, in a question, if you don't see aortic, so in a question, if you don't see aortic displacement and we see overriding aorta, please, it's the same thing. So please, let's take note, overriding aorta. So let's consider the images. This is the aorta. This is the normal heart. This is the aorta, where I'm shading. So the blood will move from the left ventricle. The aortic valve over here would open, the blood will move to the aorta. But let's look at this image. We are having an overriding aorta or a displaced aorta. Let's look at the heart with the tetralogy of Fallot. This is the aorta. This is, please, let's follow keenly. This is our left atrium, this structure or this part. And this is the left ventricle. From the left atrium, the blood will get to the left ventricle. But let's look at the positioning of the aorta. You realize that the aorta has shifted. The aorta in this image, the heart with the tetralogy of Fallot, it has shifted. Let's look at where the arrow is pointing to. It has shifted. This is the aorta. Ordinarily, the aorta, this area should connect with the top, but it has displaced, and we would appreciate why it has been displaced. The aorta has displaced because of the right ventricular enlargement. It has displaced the aorta. So displacement of the aorta or an overriding aorta is one of the structural defects of the tetralogy of Fallot. And another defect that we can clearly see from this image is the pulmonary stenosis. Pulmonary stenosis, narrowing stenosis. We said earlier that once the blood moves from the right atrium to the right ventricle, the blood will then move through the pulmonary artery, the only artery that carries deoxygenated blood. Let's look at this image. This is the pulmonary artery. Let's look at what is happening here. Let's follow the arrows. There is stenosis, there is narrowing. So, Aaron, please, do you think that the stenosis here or the narrowing here, the blood would be able to move from the right ventricle easily? Do you think that the blood will be able to move through from the right ventricle to the pulmonary circulation very easily? Looking at the structural defects, the pulmonary stenosis. Exactly. So the answer is no, it wouldn't. And we need adequate blood to get to the pulmonary circulation. But over here, the pulmonary artery has become narrowed. It has become stenosed. So we are not going to have or get adequate blood that will get to the pulmonary circulation for oxygen. So that is another structural defect. And the fourth structural defect of the tetralogy of Fallot is the septal defects. And please don't let the NCLEX trick you. We are saying that it's a septal defect, but it is a ventricular septal defect. You've seen that the defect is here, where I'm shading here. Ordinarily, the septum, so the septum, this is the septum. I'm shading the septum here. It divides the compartment. The oxygen-rich blood and the deoxygenated blood should not mix up. So the septum is there. But in the tetralogy of Fallot, we realize that there is a hole here. There is a hole in the septal wall. And that hole is to the ventricle. So if we ever come across a question that asks about the structural defects of tetralogy of Fallot and we see the atrial septal defect, please, let's run away from that option. It is a ventricular septal defect, ventricle. So into brackets, ventricle. So it is a ventricular septal defect, not an atrial septal defect once again. So what happens here? There shouldn't be any connection between the right ventricle and the left ventricle, but that is not what we are seeing here. So it means that the oxygenated blood and the deoxygenated blood can mix up, which is so abnormal. So Aaron, these are the four structural defects of the tetralogy of Fallot, and we should take note of this. These questions should be bonus questions. So you can use the mnemonic RAPS, R-A-P-S. So we can use the mnemonic RAPS. The tetralogy of Fallot labs RAP, or it labs RAPS. So RAPS, right ventricular hypertrophy, aortic displacement, pulmonary stenosis, septal defects. The septal defects, we've said that it is the ventricular septal defect. So please, let's take note of this as we move on. Please, can you hear me? Please, is there any question, any contribution up to this point before we move on? This is just the fundamental. This is just the fundamental. Please, can we proceed? Please, can we proceed? Please, we can unmute ourselves and talk, or either we chat or we key a response in the chat box. Okay, please. So please, let's take note of these 4 structural defects. Very, 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 very much important. And the fact that the Tetralogy of Fallot is a congenital heart defect. And so we are going to have cyanosis in these individuals. So please, fast forward. Let me talk about this. I've seen this a lot in Q banks. Please, the aortic displacement is not the same as coarctation of the aorta. So please, let's take note. I've seen Q banks and option that will try to trick you. We talked about the coarctation of the aorta under the obstructive heart defect, that in the coarctation of the aorta, there is a narrowing of the aorta. So with the Tetralogy of Fallot, we are not having a narrowing of the aorta, but rather we are having an overriding or a displaced aorta. So please, let's take note. It is not the coarctation of the aorta. It is a displaced aorta. So please, let's take note of this point very, very, very well. Don't let any Q bank trick you. It is an overriding aorta or displaced aorta, not the coarctation of the aorta. So please, let's take note of this as well. And we've said that the hypertrophy would displace the aorta. So there is a hypertrophy that is going to displace the aorta. So how then do we diagnose this condition in the pediatric? How would we diagnose this condition? So the diagnostic investigation is one of the key NCLEX areas that, of course, we need to talk about. So it can even be diagnosed during pregnancy. This condition can be diagnosed during pregnancy, but majority of the time it is seen after birth. So the diagnostic investigation, very, very much important. We can do our X-ray. So we can take an X-ray of the heart. Once we take an X-ray of the heart, a child with a Tetralogy of Fallot, the heart, please, what will be the appearance of the heart? A child with a Tetralogy of Fallot, what will be the appearance of the heart if you take our X-ray, Aaron's? What will be the appearance of the heart, please? So please, we can key the response in the chat box. What will be the no, please. So the X-ray will not be able to show the 4 features. No. Yes, the heart can be enlarged, but usually once we do our X-ray, the heart, so we call it the boot-shaped heart. So this is an X-ray of the heart of a child with a Tetralogy of Fallot. You've seen the shape of the heart. Please, I believe you can see the shape of the heart. The shape of the heart. Please, can we see the shape of the heart? So a child with a Tetralogy of Fallot, an X-ray would reveal a boot-shaped heart. A boot-shaped heart. So please, let's take note of these key points. A boot-shaped heart. So a boot-shaped heart, we can think of the Tetralogy of Fallot. And someone may ask, why would a heart be like the boot? In fact, this is a conventional radiographic finding. In case of the Tetralogy of Fallot, is a conventional radiographic finding. And the shape of the heart turning or changing to that boot-shaped heart is as a result of the upward displacement of the right ventricular apex. We are very much aware that the heart is like an inverted cone, a cone that we've turned upside down. It is like an inverted cone. So the apex, if this is the heart, this is the apex, right? The apex of the heart, and not the top. Ordinarily, we might think that apex means top, but the heart is like an inverted cone, a cone that we've turned upside down. So this boot-shaped heart is as a result of an upward displacement of the right ventricular apex. And it is as a result or as a consequence of the right ventricular hypertrophy. So in summary, it is a right ventricular hypertrophy that is resulting in the boot-shaped heart or the disappearance of the heart. So once we do our X-ray, we can see this boot-shaped heart, which is a conventional radiographic finding. And we are saying that it's as a consequence of the right ventricular hypertrophy. So an X-ray can be done. if you want to diagnose a patient or a child with a tetralogy of Fallot. Of course, we can also do our echo, what we call the echocardiogram. Echocardiogram. I usually love to describe this as the ultrasound of the heart. So you can do our echocardiogram. So usually the echocardiogram would help us to confirm echocardiogram. So you can think of it as an ultrasound of the heart. So an echocardiogram can also be done. Or we can look at the clinical findings or the clinical presentation. So right from here, we're going to look at another key NCLEX area, a child with a tetralogy of Fallot, the signs and symptoms that they will present. As part of our diagnostic investigation, we can base on the clinical findings. What is the child exhibiting? And it can give us a clue that this child may be having the tetralogy of Fallot. So that is one of the key things that we need to consider. Another common diagnostic investigation is the cardiac catheterization. Cardiac catheterization, catheterization. So a child with the tetralogy of Fallot, you can do the cardiac catheterization. Let me get an image of the cardiac catheterization. With the cardiac catheterization, we just want to pass a flexible scope. Usually we use the femoral artery, the artery around the groin, the femoral artery. So with the cardiac catheterization, the key thing is that we want to pass that flexible tube, and the tube would then get to the heart so that you'll be able to visualize the heart. So that is for the cardiac catheterization. So the cardiac catheterization can also help us to establish our diagnosis of, so this is a funny image of the boot-shaped heart. So you see that the image to the right has the boots. So that is one one diagnostic investigation that we've talked about. So let me get an image, a very brief image of the cardiac catheterization. So what we are saying is that with the cardiac catheterization, we want to pass. Please, can you hear me? Okay. Yes, we can hear you now. Sure. Okay, thank you. Sorry, I lost my connection. Sorry. Yeah, so please, we're on the cardiac catheterization. So we're saying that one of the diagnostic investigation or the approach that we can use to diagnose this condition is the cardiac catheterization. And we are saying that a thin flexible tube, the catheter will be advanced, as we can see from the image. And we advance it and it will get to the heart. So we're able to see the defect. So we can see the structures, the inner structures of the heart, and we can also see the defect as well. So cardiac catheterization can be done as part of our diagnostic investigation for a child with the tetralogy of Fallot. Please, this just by the way, never get question on cardiac catheterization wrong. We realize that cardiac catheterization is not only to tetralogy of Fallot. Any condition that we want to visualize or we want to ascertain if there is a structural defect or if there is a defect inside of the heart, we can do the cardiac catheterization. So the key NCLEX points on cardiac catheterization, let's take note of this. We are saying that we usually use the probe or the flexible tube or the catheter. It's usually inserted in the femoral artery, which is around our groin. Sometimes we can use the jugular access, but most commonly we use the femoral artery. So questions on cardiac catheterization, let's not get it wrong. You realize that in this condition, we want to visualize the structures. So for it to be very, very, very much brighter or much clear, they sometimes use a dye or a contrast for this procedure, contrast or dye. So one of the key NCLEX points about cardiac catheterization is that you have to assess the patient for what we call the dye allergy or the contrast allergy. So assessing this patient for contrast allergy or the dye allergy is very, very much important. And how do we assess? The patient will tell you, if one of the common options in the Q bands, you ask the patient if they are allergic to shellfish. If the patient is allergic to shellfish, it means that there's a possibility that they would have an allergy to the dye or to the contrast. So we are saying that the dye helps the images, or it helps in better visualization. But some individuals are allergic to the dye. So assessing for dye allergy or contrast allergy is very important. And one of the common options in QBank, assess for shellfish allergy, which means that the patient may have an allergic reaction to the dye. And having the reaction to the dye, of course, it can be very, very lethal. So that is why we need to do this assessment. But then this is not an absolute contraindication. Previously, it was thought that when the patient has the allergy to the contrast or the dye, we cannot continue with the procedure. But now research has proven that it is not an absolute contraindication. It is not an absolute. So if they're having the allergy or a previous allergy to the dye, we can give them our prednisolone, or we can give them our methylprednisolone, so that it would prevent, or it would protect the patient from having that reaction. So cardiac catheterization, assessing for dye allergy, very, very much important. And because we are going to use the dye or the contrast, we have to ask the patient we have to ask the patient if they are diabetic. Please, why do you have to ask them if they are diabetic? If the patient is diabetic, why do you have to ask them? The patient, why do you have to ask if he or she is diabetic? Is that even important to ask if they have diabetes? We're going to do the cardiac catheterization. We're going to give a contrast or the dye. Please, can you hear me? Please, can you hear me? Okay, so we need to, yes, we need to ask them, because it can cause what? Yes, we need to hold the metformin. Why do we need to hold the metformin? So the key point is that any procedure, it is not only cardiac catheterization, any procedure that that involve the use of contrast, even a hair CT with contrast, the fact that we've seen the dye or the contrast, we hold metformin. So we have to hold metformin 48 hours to 72 hours before the procedure. Why do we hold the metformin? Metformin is an oral hypoglycemic agent. It falls under the biguanine class of the anti-diabetic, the drugs, metformin. We hold the metformin for 48 hours to 72 hours. Why? To prevent lactic acidosis. So that is why we do what? That is why we hold the metformin for 48 hours to 72 hours. Very, very common in the kill banks. Not just that. We are saying that the cardiac catheterization, the probe, we usually use the femoral artery. We know how artery bleed. If you are bleeding from an artery under very high pressure, you can bleed a lot. So after the procedure, we need to monitor the patient for bleeding. So monitoring the patient for bleeding is also very, very much important. Assessment in general is very, very much important. The neurovascular assessment, very much important. And we are using the femoral artery. We are using the a blood vessel from the groin. So it is equally important that after the procedure, the pulse strength, the strength of the pulse should be checked. The strength of the pulse. Some questions you see, the pedal pulse, Why do we need to assess the pedal pulse? It is this same femoral artery, it runs down. So if there is a hematoma or if there is a blood clot as a result of the procedure, do you think blood will be able to flow down the extremity? The answer is no. So if there is a hematoma formation, the pedal pulses will be diminished or it will be absent. So in the prioritization question, the patient who has just undergone cardiac catheterization, who is having an absent pedal pulse, it is abnormal. It can be a hematoma, a blood clot formation that is that has occluded the blood vessel, the artery, as a result of the procedure. So the pulses, if you check the pedal pulses, is going to be diminished or absent. So please, let's take note. So assessing for the pedal pulses, very, very much important. So because the patient stand at a risk or greater tendency of bleeding, we need to apply pressure. Please, we want to move very fast. We need to apply pressure to the incision sites. Why do you want to apply pressure? You want to apply pressure to stop or to minimize the chances of bleeding. That is why you want to apply pressure. And then another key NCLEX point, very common in questions. Patients after this procedure, we limit their motion. Patients after a cardiac catheterization, we limit their motion. Which of the following do we need to intervene? Patients after cardiac catheterization immediately tell the nurse that they are ambulating to the urinal or to the washroom. No, we limit motion of the affected extremity. We limit motion, and the reason is to prevent bleeding. So please, that is also very important. And in as much as we are limiting the motion, we put the patient in a supine position. So please, these are key NCLEX points on cardiac catheterization. We limit the motion of the affected area for at least 6 hours, and they have to be in a supine position. Please, a patient who are just undergone cardiac catheterization, do we apply warmth or do we apply hot compress or warm compress? Please, would we do that or would we go in for it? If we see it in any question, warm compress. Warm, that's what? Warm dilate, right? So warm compress is a no-no. So no warm compress. Okay, so please, I usually use the same symbol for no and not fracture. I usually use the symbol for no. No, right? So no warm compress. Warm compress at the incisional site is going to cause bleed. Warm dilate. So no warm compress. We don't have to encourage ambulation immediately after the procedure. We don't do that. So all of these points, very, very much important once we are answering questions on the cardiac catheterization. And because the patient can bleed, definitely if they are on blood thinners, the heparin, the warfarin, the aspirin, what should they do? They should stop it. So we usually stop the blood thinners, right? So 2 to 3 days prior to the procedure, you stop the blood thinners. Why? Because if they're taking the blood thinners, they can bleed. Their tendency of bleeding to become very, 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 very high. So that is why we need to stop the blood thinners before the procedure. So please, this is just by the way. So questions on cardiac catheterization, these points, very, very, very much important. So back to our discussion, we can do our X-ray, we can do our echocardiogram, we can base on a clinical manifestation or the clinical presentation, or we can do our cardiac catheterization, very, very much important. Now, I want us to move away from here and consider one of the key NCLEX areas, the signs and symptoms, a patient with Tetralogy of Fallot. Please, I always say that NCLEX is all about content. Signs and symptoms, you don't need to memorize it. Just understand what goes on in the condition. Tetralogy of Fallot, 4 structural defects. We said that it will lead to what? Cyanosis. It's a cyanotic heart defect. So a patient who is having cyanosis or a patient who is having a decreased amount of blood getting to the pulmonary circulation. If there's less blood getting to the pulmonary circulation, less blood would return back to the heart at the left side. So it means that we are going to have less of oxygenated blood moving or leaving the aorta to the systemic circulation. So we are going to have hypoxia. So if you have hypoxia, what are some of the signs and symptoms that the patient would exhibit? So that is all. So once you understand what happens in the condition, the signs and symptoms will come in automatically. So for the signs and symptoms of the Tetralogy of Fallot, we can use a nice mnemonic. Do we give pre-medication to help with the clotting? Marion, I don't really get your question very well. Yeah, so with the signs and symptoms, we can use our nice mnemonic. We are saying that Tetralogy of Fallot afflicts kids. It afflicts individuals. It can affect the child. It can harm the child. It can affect the normal life of the child. So one of the signs that we talk about is that if the child performs an activity, if they perform activity, they would have what? They have activity intolerance. So if they involve or they get themselves in strenuous activity, they can be cyanosed. So activity, this kid can be cyanosed. So that is for the A, they can be cyanosed, or they can have the shortness of breath. They can have the shortness of breath. Please, let's build on this point. There are quite a number of points that we need to capture under the activity. It is not only strenuous activity. Sometimes if they are breastfeeding, if they are breastfeeding or bottle feeding, and we do it rapidly, or even if the nipple of the bottle is very, 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 very small. If the nipple of the bottle is very small, it means that they will use more energy to take the food from the bottle. So in this instance, using more energy required that you have adequate oxygen in your body. But in case of the Tetralogy of Fallot, it is not so. So performing strenuous activity, sometimes even feeding, it can lead to what we call the TET SPELL. Please, there are a number of questions on the TET SPELL. Under Tetralogy of Fallot, another key NCLEX point or NCLEX area that you have to recall is what we call the TET SPELL. So, or you can picture it as a crisis. Already, they are having the cyanosis, they are having that inability to grow and all of that. But when they engage themselves in strenuous activity, they can have what we call the TET SPELL. In questions, if you don't see TET SPELL and you see hypercyanotic spell, it is the same thing. Hyper means up or above, right? Hyper. So worsening cyanosis. So the key point is that TET SPELL simply means that we are going to have a worsening of the signs and symptoms that they are going to exhibit. We are going to have a crisis. In crisis, things go bad. So TET SPELL or hypercyanotic spell, they're going to have severe cyanosis. This child is going to turn bluish. So please, under the activity, let's take note of this, the TET SPELL. So then I ask, how can we see or how can we know if the patient is having the TET SPELL? The signs and symptoms that they are exhibiting, everything is going to be worse. The cyanosis is going to be worse. So that is why we also call it the hypercyanotic spell. So this child is going, so please, are we going to have an increase in respiration or a decrease in respiration? A child with a TET SPELL, an increase or decrease in respiration? An increase or decrease? TET SPELL, an increase or decrease? Aren't an increase or decrease? Please, anyone? Are you going to have an increase? Exactly, we are going to have an increase in the respiration. TET SPELL. The child can use the accessory muscles. So they can use the accessory muscles to aid in respiration, which indicates that we are having problem or we are having respiration difficulty. So they can have an increase in respiration. They can use the accessory muscles. The SpO2 can decrease. The SpO2 can decrease. They will have severe shortness of breath. To some instance, this kid can even faint. A child with a TET SPELL, they can even faint. Fainting. Why would they faint? They're having hypercyanosis. The hypoxia is worsening. If you're having less amount of blood, less amount of oxygen in our blood, hypoxia. What of the brain? The brain needs to be perfused. The cerebral perfusion pressure should be adequate. The brain needs to be perfused. The brain is not perfused. This child can even faint. So a child exhibiting this, we can think of a possible TET SPELL. And even their color, their skin color will change. It will be cyanosed. And we are very much aware that cyanosis is a late sign of hypoxia. So please, let's take note. Let's know the early sign of hypoxia and the late sign of hypoxia. I've seen quite a number of questions in the various skill banks. Cyanosis is a late sign of hypoxia. Please, let's take note. So with a TET SPELL, yes, so that is one of the key area that we need to look at, the TET SPELL, or what we call the hypercyanotic spell, because we're going to have a rapid drop in the amount of oxygen in the blood. So that is why we are going to have the TET SPELL. So please, common questions on the TET SPELL. We are still on the A. We are still on our mnemonic, the A. Common questions on the TET SPELL. We'll talk about it in details, but let's just put this across. Some questions ask about if the patient is having the TET SPELL, what do we do? What do we do? Aren't. In terms of the positioning, what do we do? A child with TOF who is having a TET SPELL, the positioning, what do we do? The first thing to do in such questions, Aaron, is to look at the age of the child. The age of the child would influence your answer. A child with a TET SPELL the age is very, very much important because the TET SPELL, the position, we can let the child squatting, or we can put the child to the knee to chest position, knee to chest position. So putting the child in the knee to chest position or squatting can help resolve the TET SPELL. So that is one of the approach that we can use. But please always check the age. Please, can we also say the late sign of cyanosis is the TET SPELL? The late sign of, no, please. The late sign of the cyanosis is a TET SPELL. No. We are saying that with the TET SPELL occurs, over here, the Tetralogy of Fallot, we are having an imbalance between the oxygen supply and the demand because of the structural defect. So the TET SPELL occurs when there is a rapid drop of the amount of oxygen in the body. Rapid drop of the amount of oxygen in the body. That leads to the TET SPELL. So if you have a rapid drop of the amount of oxygen in the body, that will lead to the cyanosis. And the child can even faint. So let's always check the position, the age of the child in questions. The child can squat. We can put them in the knee to chest. This is an image of the knee to chest position. Knowing the various images are also very much important. Assuming you get a question and you don't see in writing knee to chest position, but rather you see the images. So you have to go in for an image that depicts the knee to chest position. So this is the knee to chest position. I believe you can all see the image on the screen, the knee to chest position. So this is the knee to chest position. So please, let's take note. So why did I make mention of the fact that always check the age? Infants, for infants, we put them in the knee to chest position. For squatting, please. Can you tell an 8-month-old to squat? No. So please, the age in the question is very much important. For an infant, the knee to chest position. But for older children, we tell them to squat. So they squat. So as we move along, we'll talk about why the squatting tends to help relieve the TET SPELL. So two positions, either the squatting or the knee to chest position. But as we said, always check the age. If it is an infant, knee to chest position. If it is an older child, then they can squat. So that is one of the key things. So if the mother is feeding the child and they had a TET SPELL, they should stop feeding the child. They stop feeding the child. We put them in the knee to chest position. Puts them in the knee to chest position. So please let me ask this: why do we put them in the knee to chest position, or why do we tell them to squat? Why do we tell them to do this at all? Let's do this before we move on. So if they assume this position, it decreases what we call the right to left shunting. It decreases the right to left shunting. Please let me take my time and explain this point very well. The Tetralogy of Fallot, we saw one structural defect, the ventricular septal defect. If this is the heart, this is our right ventricle, this is our left ventricle, and there is a hole and there is a hole here. So if there is a hole here, it means that the blood from the right ventricle can enter the left ventricle. So there is a right to left shunting. So that is what we refer to as the right to left shunting. And the right to left shunting means that the deoxygenated blood at the right is going to mix with the oxygenated blood at the left, which is bad. Very, very, very bad. So if they squat or if you put them in the knee to chest, it decreases that right to left shunting, which is very bad. It decreases it. Why does it decrease it? If a child is to squat, or if you put them in that knee to chest position, what happens is that squatting. So please, let's picture it. Squatting decreases the lumen. Please let me get an image of the heart so that we appreciate why the squatting would help relieve them of the hypercyanosis. Please, this is an image of, okay, let's get an image of the Tetralogy of Fallot. So I think that one would really help us. Let's get an image of the Tetralogy of Fallot. Right from here, we're going to move quite fast. We have a number of things to talk about. Okay, so please, let's have a look at this. we are seeing this, the ventricular septal defect. So we are having a right to left shunt, right to left shunt. And we are saying that if they squat or we put them in the knee to chest position, what it does is that it decreases that right to the left shunt. And decreasing the right to the left shunt would, of course, help to decrease the shortness of breath. In other words, it would help to decrease the dyspnea. So in one question, a patient, the mother place the child in a knee to chest position. For it to see that this position is effective, what should we identify? We should identify less dyspnea, less difficulty in breathing, because assuming this position will help the child to breathe very well, so you're going to have less dyspnea. So if the child squats, what happens is that squatting decreases the diameter or the lumen of the aorta. So please, let's follow. Squatting would decrease the diameter or the lumen of the aorta. So that is why in some resources, you look at it and they will tell you that squatting or putting them in a knee to chest position, it increases what we call the systemic vascular resistance. So that is the broader term for it. It increases the systemic vascular resistance. So there's the explanation. If they squat, the diameter or the lumen of the aorta, it decreases. Please, if the lumen of the aorta decreases, would the left ventricle amass high pressure to push blood or less pressure to push blood? Would it require the left ventricle to use high pressure or low pressure if the lumen of the aorta decreases? The diameter has decreased. This is the aorta. This is the aorta. This is the aorta. If the diameter decreases, would the left ventricle use more pressure or less pressure to push the blood? All right. More pressure or less pressure? Exactly, high pressure. High pressure. So the position increases the systemic vascular resistance. In easy terms, we can say that it increases aortic resistance, the resistance in the aorta. If it increases the aortic resistance, now the left ventricle is trying to push the blood, but because there is resistance there by virtue of the positioning, if there is resistance, what is going to happen is that the blood is going to be forced to move from the left ventricle to the right ventricle. So ordinarily, the blood would have moved from the left ventricle through the aortic valve and up through the aorta and out. But if the pressure here or the resistance here is very, very high, very, very, very high, if the resistance here is very high, the blood will not be able to move smoothly. So there's going to be a lot of resistance. So that resistance is going to cause what we call the reverse shunting, reverse opposite. Ordinarily, in the Tetralogy of Fallot, we're having a right to left shunting, right to left. The deoxygenated blood is moving from the right side to the left side. But because of the resistance that we're going to create in the aorta by virtue of the positioning, we're going to have a reverse shunting. The reverse shunting means that we're going to have an L to R shunting. In other words, that pressure is going to prevent the movement of the blood from the right ventricle to the left ventricle. So preventing that shunting of the blood from the right ventricle to the left ventricle is going to help the child to breathe very well. So that is why we put the child in that squatting position. So once again, we increase the aortic resistance. We increase the aortic resistance. In other words, we can say that we increase the systemic resistance. Once we increase the resistance, there's going to be a lot of pressure, a high pressure. So that high pressure is going to decrease because that high pressure will be all over here. So that high pressure is going to decrease the flow of the blood from the right to the left. So if we're able to decrease the flow of the blood from the right to the left, of course, we are doing something good because we don't want the blood from the right to move to the left. So creating this resistance by squatting would help to decrease or to reduce the right to the left shunting. So that is why we tell them to squat or put them in the knee to chest. So if we decrease the right to the left shunting, it means that more blood would get to the lung. I believe we understand why more blood will get to the lung, because ordinarily, if you see the image, the blood that has accumulated the right ventricle here, some of the blood would move through this hole and it will get to the left ventricle. So you're going to have less blood moving through the pulmonary artery. But if you're able to prevent that shunting, that movement of the blood, we're going to have more blood that will get to the lungs. So we are going to have more blood that will get to the lungs. The net effect is that you're going to have a decrease in the hypoxia. If you're having a decrease in the hypoxia, the patient or the child is going to feel better. So that is why we put them in the knee to chest position, or we tell them to squat. So that is another bonus question, but always check the age of the child, which is very, very much important. So please, away from here, let's go back to our mnemonic. So we've talked about the A, we've talked about the activity. What of the F? Fingernail changes. So once again, I use this sign for changes in maths, change in Y over change in X. So I use this sign for change. So fingernail changes. Why would they have a fingernail change? And with the fingernail changes, what term are we using? Clubbing of the fingernail. Clubbing of the fingernail. Clubbing of the fingernail indicates what? A chronic hypoxia. So there's not only tetralogy of Fallot that can have the clubbing. So the clubbing of the fingernails will come in if the child experiences chronic hypoxia. Even in COPD, conditions that would result in chronic hypoxia, you can have fingernail changes. And that fingernail changes is what we call clubbing. I wish I have an image, but then if we are to take the image of the finger, so let me just draw something small. So assuming this is my thumb or this is my index finger. So let's just use this. So let's just use this. So assuming this is my finger. So realize that the angle that is formed by the nail bed, the angle here. So we can picture it. We can raise one of our fingers. You realize that the nail forms an angle with the bed. That angle should be around 160 degrees. But somebody with clubbing, please, can someone send an image of the club fingers on the Telegram platform so that we have a look at? I don't want to go online because the network might mess up. So a patient with clubbing, instead of the fingernails, that angle to be 160, you realize that their fingers will be like this. Like it will be like this. That angle here is going to be more than 180. Going to be more than 180. So that is what is referred to as clubbing of the fingers. And clubbing of the fingers indicates, okay, so I think we have an image. So clubbing of the fingers indicates chronic hypoxia. So there's a very nice image of the clubbing. Let's drop this image. I believe you can see this image. So there's the clubbing. You've seen how the nail appears, So clubbing of the fingers indicates chronic hypoxia, and that can be seen in cases of the Tetralogy of Fallot. So F for fingernail changes, or you can use that same F for fatigue, So the second F of the afflict is fatigue. So the child would experience fatigue, or fainting. So we said that the child can even faint. So fainting can be seen when a child is having the Tetralogy of Fallot. So afflict, AFFL. So the L talks about the positioning. So the positioning left towards, left to knee to chest, left to knee to chest. And that is for what? For the infant. Or they can squat for what? The older children. So the L talks about the positioning, left to knee chest position. If there's an infant, but if it's an older adult, then they squat. Afflict, AFFLI. I means that inability to grow. A child with a Tetralogy of Fallot and a normal child here means that a child without the Tetralogy of Fallot if you are to compare their developmental milestone, a child with a tetralogy of Fallot would experience an inability to grow, what we usually call the FTT, the failure to thrive, inability to grow. So we call it the FTT, failure to thrive. They will not attain the normal weight and height, inability to grow. So we call it the failure to thrive. They would have a delay in their developmental milestone. So that is for the I. So let's get like a very nice place and write. So that's for the I. And of course, the C is cardiac sound, cardiac sound. So a child with a tetralogy of Fallot, if we are to auscultate the heart sound, we can have an abnormal heart sound. So C for cardiac sound. A child with a tetralogy of Fallot, we can have a systolic memo, or a trill, a systolic memo or a trill. And please, we are not looking at this, but let me just take 2 minutes and explain this. I've seen some questions on this very point. The child would have a systolic memo or the trill. That systolic memo or the trill, which is an abnormal heart sound, it is as a result of the pulmonary stenosis. The pulmonary stenosis. We talked about the stenosis as a result of, as one of the structural defects, the pulmonary stenosis. The pulmonary artery is stenosed. So ordinarily, what would the body try to do? The body will try to pump, so let's use the right ventricle. So the right ventricle will try to pump the blood at a very high pressure just to overcome the stenotic area or the region. So in doing that, and because of the stenosis, there can be an abnormal sound because of the stenosis. So that is what we call the systolic memo or the trill. So it means that the stenosis is around the pulmonary artery, along the pulmonary artery. So if you ever get a question on tetralogy of Fallot, and this question is asking you that if we are using our stethoscope to auscultate the heart of a child with a tetralogy of Fallot, where would we put the stethoscope? Where would we put the stethoscope to listen to that systolic memo? We are putting the stethoscope at the pulmonic area, where we can find the pulmonic area or the pulmonic valve. Why are we putting it there? Because the stenosis is at the pulmonic area or the pulmonic region. So that is where we are going to put the stethoscope at. So some common questions. Where are we going to put it in terms of the intercostal spaces? Please, we want the pulmonic area or the pulmonic valve. Where are we going to put the stethoscope? Which intercostal spaces, Aaron's? Which intercostal spaces? Yes, Aaron Joel, left second intercostal space. Please, I believe we all agree that is the left second intercostal space. I believe we all agree. This question, of course, should be bonus question. This forms part of the fundamentals, the cardiac landmarks. Cardiac landmarks, very, very much important. We have, so we can use the mnemonic ape to man. I personally love ape to man. Ape to man. Ape to man. So I personally like ape to man. So these are the cardiac landmarks. You can use ape to man. Just write like this. So this is the this is my left, and this is my right. So it means that when we talk about cardiac landmarks, at the right side, only one point, that is the aortic area. Only one is at the right. The remaining 4 is at the left. So if the first intercostal space, there is nothing at the first intercostal space. So that is why with this image, we are seeing it's starting or beginning from the second intercostal space, right? So if the question is asking about where we are going to hear that systolic memo, it is as a result of the pulmonary stenosis. So we are going to put the stethoscope at the pulmonary region, where we are going to find the, we are going to put it at the pulmonary region. So please, that is what I just wanted to put across so that we don't get those questions wrong. Ape to man. Those questions should be bonus. Which side can we find the F point? You just draw your ape. Or you just draw this drawing, knowing that the first intercostal space here, there's nothing there. There's nothing there. Everything starts from the second intercostal space. So you can just do 2, 3, 4, and 5. Where would we find our pulmonic valve or the area, second intercostal space to the left? Where would we find the Epps point, third intercostal space to the left? Where would we find the tricuspid point, fourth intercostal space to the left? That is left of the sternal border. Where would we find our mitral point? The mitral point is the same as the apical, the apex of the heart. The apex of the heart, the apical, or what we call the point of maximum impulse. So that is, that one is very, very, very special. So the 5 is the mitral or the apical. It is the left or right. Yes, we can see that it is the left, but it is not close to the sternal border. This is the sternal bone, the sternum, or the breastbone. Realize that the 2, 3, 4, they are close to the sternal border. But for the 5, it is mid-clavicular, left side, but it is mid-clavicular. There is the collarbone, the clavicle, and it is mid-half. So mid-clavicular, you find the apical, or what you call the mitral, or sometimes you see the point of maximum impulse. But if the question is about the aortic valve or the aortic point, is the right second intercostal space. Right second intercostal space. So that is just by the way. So those questions, not so much difficult. So let's take note of that as well. So that is for our C, cardiac sound. So that is where we are going to have the cardiac sound. And lastly, with the T of our afflict, this child will have problem or trouble feeding. Feeding will become an issue. They would have trouble feeding. And that same T for trouble gaining weight. You can even link the trouble gaining weight to the failure to thrive. So please, that is some of the signs and symptoms that you can find in a child with the Tetralogy of Fallot. Please, let me ask this important question. A child with Tetralogy of Fallot, can they experience polycythemia? Can they experience polycythemia? A child with Tetralogy of Fallot, can they experience polycythemia? Yes, RN, yes, they can experience polycythemia. What is polycythemia? An increase in the red blood cell. Polycythemia, plenty red blood cell in the body. So the blood will become so viscous, or what we call hyperviscosity in polycythemia. Yes, we are not looking at it though, but we have the types of the polycythemia, the primary and the secondary. So the primary is what we usually call the polycythemia vera. The problem is from the bone marrow. The bone marrow is creating more of the red blood cell. So creating more of the red blood cell makes the blood very, very, very thick or very viscous. That is not what we are looking at here. We are looking at the secondary polycythemia. So this is secondary. So we are looking at secondary polycythemia. And the secondary polycythemia, they are usually as a result of an underlying condition. Usually those conditions would result in hypoxia. Even COPD, the patient can, I am having the hypoxia. My body would think that, why don't I produce more of the red blood cell? Why don't I produce more of the red blood cell as a compensatory mechanism? Because we know that the red blood cell has an affinity for oxygen. So if I'm having hypoxia, the body will compensate. It will produce more red blood cell, knowing that the red blood cell will bind to oxygen and it will deliver the oxygen to the tissues, to the organs that are in need of the oxygen. So that is why, as a compensatory mechanism, a child with Tetralogy of Fallot, they can have polycythemia. So please, let's take note. So in a prioritization question, a child with Tetralogy of Fallot, whose hemoglobin, the HB level of the child is 22. The HB, 22. Please, we need to report to the healthcare provider. And we are very much aware of the correlation between hemoglobin and hematocrit. Hematocrit, the proportion of the red blood cell to the volume of the blood. We know that the blood is made up of red blood cell, white blood cell, the plasma, the platelets. So that proportion of the red blood cell to the various blood components is what is referred to as the hematocrit. 3 times the hemoglobin gives the hematocrit. We are very much aware of this. So in a question, a child with Tetralogy of Fallot, the HB is 22. We need to report to the healthcare provider. Or if the hematocrit in the question is over 65%, we need to report to the healthcare provider, because this is a secondary polycythemia. The child's body is trying to compensate because of the hypoxia. The body is creating more red blood cells with an attempt or with a mindset, quote unquote, that the red blood cells would bind to the oxygen and it would deliver it to the, or to help to meet the metabolic demand of the body. But polycythemia the child would be at a huge risk of what? Of clots, because polycythemia makes the blood so much viscous, very, 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 very thick, hyperviscosity. So the polycythemia, the child will stand at a huge risk of blood clots. So that is why we need to report to the healthcare provider if the child is having this abnormal hemoglobin or an abnormal hematocrit. So please, let's take note of this. Very, very, very much important. A child with the Tetralogy of Fallot, they can even have a seizure episode. At a point in time where we don't resolve the hypoxia can lead or can worsen, and we can have what we call anoxia. What is anoxia? Hypoxia, less oxygen in the blood. Anoxia, we are having what? An absence. The oxygen level has decreased drastically. So if it gets to this point, in fact, this child can have anoxia. This child can have anoxia. So with the anoxia, clearly it will lead to death because you can't breathe without oxygen. So that is why we need to intervene promptly. So they can even have a seizure episode. We can have a seizure episode as well. So that is basically some of the signs and symptoms that we need to capture for the NCLEX. And Aaron, the last aspect of our discussion that we will look at is the nursing management. We've already talked about all of these points. We've talked about all of these. A child with a Tetralogy of Fallot, what would we do for this child? The key thing here that we want to actually look at is the TET SPELL. The TET SPELL. We want to look at the TET SPELL. So what would we do for this individual? So that is what we're going to look at, the nursing management. So we monitor the child for the TET SPELL or the hypercyanotic spell, and then we intervene. And with the intervention, we've talked about it. We stop the feeding, right? We stop feeding. If it occurs during feeding, we stop the feeding and we put the child to the knee to chest position. If it is an infant, if it is an older adult, what do? We tell them to squat, and we explain why the squatting, the knee to chest position, helps to decrease the dyspnea. So another key NCLEX nursing management that we also talk about is the fact that if they sleep, we don't interrupt their sleep, because crying, don't interrupt sleep. Crying can bring about the TET SPELL. So if they are asleep, we don't want to wake them. So we don't interrupt their sleep. As much as possible, we need to nurse the child in a calm and quiet environment. Less stimulation. We don't want to stimulate the child to cry. So calm and quiet environment. So if they are even crying, we can give them a pacifier. We can give them a pacifier when they are crying, at least just for them to stop crying. So we want to prevent the TET SPELL. So this one is very, very much important in our discussion. So we are saying that feeding can bring about a TET SPELL. So it is very much important. If you see in questions, we need to feed this child small feeding, but it should be frequent. So that is where what we say, small but frequent feeding. Small but frequent feeding is good. It decreases the workload on the heart. Feeding the child plenty at a go or more at a go would increase the workload on the heart. So we feed the child small but frequently. So please, let's take note. Please, can you hear me? Please, can you hear me? Please kindly confirm if you can hear me. I had a call coming through. I have done a hotspot from the phone to the laptop. Okay. So small but frequent feeding is good for this child. And in as much as possible, we want to calm this child, calm the child. Very, very much important. And please, can Tetralogy of Fallot lead to heart failure? Can Tetralogy of Fallot lead to heart failure? Aren't. Can this condition lead to heart failure? Yes. It can lead to heart failure. So as much as possible, we need to watch out, or we need to monitor the child for a possible heart failure. I've seen a question like that. A child with Tetralogy of Fallot, which findings would indicate that the child is having a heart failure. So in the options, just look out for signs and symptoms of heart failure, and then you are just done. The selector does apply, you are done. So you watch out for heart failure, not just heart failure, you also watch out for CVA or stroke. Somebody may ask, hey, why would a child get stroke or get CVA, cerebrovascular accident? Is as a result of what? Of the polycythemia. The blood becomes very, very, very thick as a result of the polycythemia. And that polycythemia is a secondary polycythemia. It's as a result of an underlying condition. That is why the body is producing too many of the red blood cells. What would happen to the blood delivery to the brain? Because the blood is very thick, the blood delivery to the brain can be very, very, very bad, or can be very poor. We need to have an adequate cerebral perfusion pressure. Please, what is the normal cerebral perfusion pressure? Please, the normal cerebral perfusion pressure, Aren't. What is the normal cerebral perfusion pressure? The normal cerebral perfusion pressure, please. We should know the formula of ICP, MAP, and that of the CPP. We should know. Cerebral perfusion pressure formula, we should know, and we should know the normal. Please, what is the normal cerebral perfusion pressure? Please, anyone? The normal cerebral perfusion pressure, Aren't. Yes, 60 to 100. Yes, 60 to 100 millimeters of mercury. So there is a normal cerebral perfusion pressure, the normal CPP. So please, let's revisit, or let's look out for the formula. Some questions you'll be asked to calculate the CPP, the cerebral perfusion pressure. You should know the normal. MAP minus ICP will give you the CPP. I believe that just by the way. So we also have to watch out for stroke, because the blood is very thick. The blood flow to the brain can become diminished. And we know the types of the CVA, ischemic and hemorrhagic. The ischemic aspect has to do with poor delivery of oxygenated blood to the brain. It can lead to the CVA. So that is why we've included the CVA aspects in our discussion. So we watch out for CVA. So please, let's take note of these points as well. So basically, we are left with the treatment, and we are done with our discussion for today. The treatment. How would we treat a child who is having the Tetralogy of Fallot? The treatment. How would we treat a child who is having the Tetralogy of Fallot? So let's have a look at the treatment. With the treatment, we can do the surgical management, and we can also do the medical management. So let's talk about the surgical. Our time is almost up, so let's speed up a little. So we can do the surgical management. With the surgical management, generally, the surgery is preferred when the child is 4 to 6 months of life. We want the child to gain ideal weight before we do the surgical approach or the surgical repair of the defect. 4 to 6 months, we want the child to get ideal weight before we do the procedure. So surgical management, what do you want to do? We want to fix, so the summary is that we want to fix the structural defects. So that is what we want to do. We want to fix the structural defects. So when we're having the ventricular septal defect, why don't we patch, or why don't we fix the defect, or why don't we close it? So surgery can be done to close the ventricular septal defect, the hole between the two ventricles. We can do surgery to correct it. We can also use a stent to open up the pulmonary artery, because the pulmonary artery is stenosed, it's narrowed. So if we use a stent, we can open up the pulmonary artery. So that can be done surgically. So once we open up the pulmonary artery, it means that we're having more blood flow that would get to the pulmonary circulation. So we can do all of this surgically. So in summary, we can do the surgical management. And I've seen a question that talks about a child who had just undergone the repair of the Tetralogy of Fallot, which findings would indicate that the surgery was successful. This question is a bonus question. We know the signs and symptoms that is exhibited in the child with the Tetralogy of Fallot. If the surgery is successful, those signs and symptoms will be absent. That is all. And that is what the question asks for. So if the surgery is successful, the post-op, if it is successful, we are going to have an absence of cyanosis. We are going to have that absence of cyanosis. The respiratory rate is going to be normal. It's going to be normal. So in other words, we're going to have an improvement in the signs and symptoms, or the signs and symptoms that we have seen earlier. We shouldn't see it. So we can do the surgical approach. What of the drug that we can do, that we can give? So that is for the medical stroke, the pharmacology aspect, the pharm aspect. So please, when it comes to the Tetralogy of Fallot, there's one drug that a lot of questions love to ask. There's one drug, and the name of the drug is prostadel. Prostadel. Please, prostadel is a prostaglandin medication. Prostaglandin is a prostaglandin E medication. Prostadel. This is the name of the drug. Prostadel. So a child with Tetralogy of Fallot, we can give the child prostadel. Why are we giving this child prostadel, please? Why do we give this child prostadel? Why would this drug even come to mind? We are giving this drug to the child. Please, let's understand why we give this drug to the child. We are giving this drug to the child so that the child, the drug will keep the ductus arteriosum open. That is why we want to give the prostadel to the child. So please, let's get this. The drug is not going to correct the defect. Please, let's take note. The drug is not going to correct the defect. The drug, it's just a temporal measure. The child, we are saying that surgery is usually performed when the child is 3 to 4 months, thereabout. That is when we want to correct, 4 to 6 months. That is when we want to correct the defect, 4 to 6 months. But before then, we can think of it this way. This child is having a cyanosis. In the fetal circulation, a lot happens in the fetal circulation. When the child is in utero, the lungs are not working. When the child is in utero, the lungs are not working. The lungs start to work when the child comes out. So the fetal circulation is different from the adult circulation. It's different from the adult. Yes. So the answer, yes. Marion Adoma has written the answer. So why we give the prostadel is to keep the ductus arteriosus patent or open. That is why we give the drug. But we want to explain why that is very important. But then if we ever get this in the question, the rationale for giving the prostadel is to keep the ductus arteriosus open or to keep it patent. And I'm just trying to say that the fetal circulation is different from adult circulation. In the fetal circulation, there are a lot of, how do we call it? There are a lot of shunts. There are a lot of shunts in the fetal circulation. But the adult circulation, there are no shunts because the fetal circulation, their lungs are not working. When the baby is born, that is when the lung starts to work. So some of the shunts in the fetal circulation, if we decide to do the fetal circulation, in fact, we are not closing anytime soon. Some of the shunts in the fetal circulation, we have the ductus venosus. Yes, I believe we can record this under ductus arteriosus, the foramen ovale, the ductus arteriosus, These are the shunts, or these are the openings. So as soon as the child is born, the opening or the shunt closes. As soon as the child is born, it closes. The child does not need this again because the lungs are coming to work. So they don't need this. They need this while they are in the womb. But if they are born, it closes after the child is born. But some kids, some of them, they have these openings not closing. So that is why sometimes it's called something the holy heart and all of that. But over here, our focus is the ductus arteriosus. That is what we want to prevent from closing up. We don't want the ductus arteriosus to close up. Ordinarily, it will close when the child is born, but we don't want it to close. So we want to give the aprostadel. So we give the aprostadel. It is just a palliative measure. It is temporal before the surgery. So keeping the ductus arteriosus, please, let's see the image. This is the enlarged image. Hello? Okay, so this is the ductus arteriosus. Let's have a look at this. So the ductus arteriosus, we've seen that it is, once they're having, it is an opening between the aorta. This is the aorta. This is the aorta, the aorta. And this is the pulmonary artery. So it is an opening between the aorta and the pulmonary artery. We don't want that hole to close at all. We need it. It's very, very, very much important. Keeping the hole intact. Ordinarily, we want the hole to close. We would close it during the surgery, but now, before the surgery, we want the hole to open. So keeping the ductus arteriosum opened, it helps or it allows more blood to flow into the pulmonary artery. We want more blood to flow into the pulmonary artery. Remember, they already have the pulmonary stenosis. Blood is not going very well. So if there is a way that we can increase the blood that gets to the pulmonary artery, from the pulmonary artery, it goes to the pulmonary circulation, then it's good. So that is why we want the connection between the pulmonary artery and the aorta. That is the ductus arteriosus. We want that connection. We don't want it to close. We want it to be opened. So keeping it open helps increase the blood flow in the pulmonary artery. If you have blood flow in the pulmonary artery, it means that we are going to have more oxygen. We're going to have more oxygenated blood returning to the left side of the heart. So that is why we give the drug aprostadel. So please, let's remember aprostadel. And it keeps the ductus arteriosum open. Aprostadel is a prostaglandin E medication. So please, let's take note of these points as well. Of course, this is really not a problem of a fluid deficit. This is a structural defect. But sometimes we can consider our IV fluids. We can consider our IV fluids, but then the IV fluids are given with caution. Please, let's take note. The IV fluids are given with caution because already this child stands at a risk of having heart failure. So we don't want to overload this child. So the whole rationale of giving IV fluid to a child with the Tetralogy of Fallot is to increase the preload. Cardiac output would increase, right? Cardiac output would increase. We know the formula for cardiac output. Cardiac output is what? The amount of oxygen-rich blood that moves from the left ventricle through the aorta. The amount or the volume of it in a minute is considered as the cardiac output in a minute. About 4 to 7 liters of blood in a minute. 4 to 7 liters of blood leave the aorta to the rest of the body. So that amount or that volume of blood is what we call the cardiac output. We're very much aware that cardiac output is equal to what? Heart rate times the strokes volume. And the strokes volume is dependent on 3 things: the preload, the afterload, and what? The contractility. The contractility. So if you're able to increase the preload, that means that we can increase the cardiac output. So that is why we would think of giving a child IV fluids just to increase the preload. And the net effect will be to increase the cardiac output. Over here, we want adequate cardiac output. We have adequate cardiac output. It would help to meet the oxygen demand of the child. And sometimes the child is also having the hyper viscosity of the blood, the polycythemia. We can also think of the IV fluid because in polycythemia, the blood becomes very thick. So as a measure to thin the blood or to make the blood less viscous, we can think of the IV fluids. But key important thing is that the IV fluid should be given with caution. It should be given with caution. So please, let's take note of this. Very, very much important. And one of the medications that you are very likely to come across in questions is morphine sulfate. Morphine sulfate. In Tetralogy of Fallot, someone may ask, morphine has a side effect of depressing the respiratory centers. So why is it that a child with the Tetralogy of Fallot, already they stand at a risk of having the hypoxia, the cyanosis? So why do we give them the morphine sulfate? Morphines, please, can you hear me? We are almost done with the review. We are, in fact, we are almost done. Please, why do we give them the morphine? Please, can you hear me at all? Please, can you hear me at all? We are almost done with the review. Okay. Okay, sure. So morphine sulfate, please, we give morphine sulfate for these reasons. Even though we need to watch out for the depression of the respiratory centers, because we know that the effects of morphine. Right. Yeah. So we know that effect of the morphine, but giving the morphine to the child, it's known to calm the child down. It calms the child. So that is one of the reasons why morphine is given, because morphine has that effect. It calms the child. In other words, it decreases the anxiety. We are not giving this drug because of pain. We are not giving it mainly because of pain. It calms the child. It decreases the anxiety. And in doing that, it is known to decrease the tachypnea, the fast heart rate. It is known to decrease the tachypnea. So that is why morphine sulfate is given when a child is having the Tetralogy of Fallot. So we can give the child morphine sulfate, especially if they're having the TET SPELL. Very, very much important. In prioritization questions or in other type of questions, put the following in an order. A child who is having the TET SPELL. What do you want to do? If you are feeding the child, we stop the feeding, right? So that is the first thing that you want to do. And you put the child to the knee to chest position. The second thing that you want to do. And you want to do what? You want to give our 100% oxygen to the child, right? After giving 100% oxygen to the child, then we can think of our morphine sulfates. And then we can consider our IV fluids. And finally, we can document. So documentation will be last. I think I saw a similar question in Sounders. So stop knee to chest position. Oxygen is very much important because they are having a hypoxia. So 100% oxygen, can think of the morphine sulfate that would decrease the tachypnea to calm the child, to decrease the anxiety. And it can help when a child is having the TET SPELL. So that is another medication that we can think of when we are considering our Tetralogy of Fallot. So that is the last but one point that we want to add up. We are almost done. One of the drugs that may be given is digoxin. Please, let's take note of this. A child with Tetralogy of Fallot, they may be given digoxin. What class of drug is digoxin? A cardiac glycoside, right? So digoxin has a positive inotropic effect, right? Digoxin has a positive inotropic. Please, can you hear me? My network messed up again. Please, can you hear me? Oh, okay, thank you so much. Sorry for that. Okay, so please, I think, yes, we are almost done. The whiteboard is still loading, but we can't wait for it. So let's use another alternative as it loads. So we were saying that we can give the child digoxin, right? And digoxin is a cardiac glycoside, and it has a positive inotropic effect. Okay, so we have the whiteboard back. So it has a positive inotropic effect. The simple term is that digoxin increases the cardiac or the heart contractility. So please, if the heart contractility increases, would the cardiac output increase or decrease, please? If we increase the contractility of the heart, would the cardiac output increase or decrease? Please, would the cardiac output increase or decrease? If you are to increase the contractility of the heart, cardiac output, the strokes, the heart rate times the strokes volume. Yes, exactly. So that is why the healthcare provider may consider digoxin. They may consider digoxin because digoxin can increase the cardiac contractility. So that is what we call it has a positive inotropic effect. Inotropic effect. So digoxin can strengthen the heart contraction. If the heart contraction is being strengthened, then it means that it can help in a way to increase the cardiac output. That is why we consider giving a child digoxin. But please, if you're giving a child digoxin, know that digoxin is a positive inotrope, but it is what? It is a negative chronotrope. It has a negative chronotropic effect. Chronotrope. Negative chronotrope means that it does what? It can decrease what? The heart rate. It can decrease the heart rate abnormally. So let's use the word abnormally. It can decrease the heart rate abnormally. So digoxin has a positive inotropic effect, but has a negative chronotropic effect. So we want the inotropic effect, the increase in the contractility is good for us in this case. But in as much as we are giving, we watch out for the negative chronotropic effect. That is the decreasing of the heart rate. So that is why before we give the digoxin, we do what? We check the heart rate. Most preferably, we check the apical heart rate. So checking the heart rate before digoxin administration, very, very, very much important. They just, by the way, if it is an adult that you're going to give the digoxin, if the heart rate is less than 60 beats per minute, we do what? We withhold and we notify the healthcare provider. If it is an infant and the heart rate is less than 100 beats per minute, we withhold the medication. If it is an older child, if it is an older kid or older child and the heart rate is less than 90 beats per minute, we do what? We withhold. So please, let's take note, because the digoxin has a negative chronotropic effect, meaning that it can decrease the heart rate abnormally. So the healthcare provider may give the child digoxin. And as much as we give the child digoxin, we watch out for digoxin toxicity. Questions on digoxin should be bonus on the NCLEX. Know the various heart rates that we have to withhold the medication. And also know about your digoxin toxicity. Know about your antidote. Please, what antidote do we give when you're having digoxin toxicity? What antidote do we give? What antidote? Digibind. We call it digibind, or we can also call it digoxin immune fab. Digoxin immune fab or digibind. That is the antidote for digoxin toxicity. So please, let's take note. A lot of questions I have to ask about the early signs of digoxin or dig toxicity. Early signs. What you prompt us early that the child is having or the patient is having digoxin toxicity. Usually the nausea and the vomiting, the vision changes. So sometimes question you see halo around light, halo around light, halo around light, or vision changes. It's a sign of digoxin toxicity, an early sign of digoxin toxicity. So please, let's take note. Let's know the early signs of digoxin toxicity, the antidote of digoxin toxicity, and the fact that we have to check the pulse before we give our digoxin. And we have to know the therapeutic, please, what is the therapeutic index of digoxin? The therapeutic index. Some questions will just give you the therapeutic index. A patient on digoxin, the level is at, let's say, 3 nanogram per ml. So it's up to us to know that is 3 within the therapeutic index or 3 is more. More means that we can have the toxic state. What is the normal digoxin level, please? Normal digoxin level, RNs. This should come very... Let's know the therapeutic index of the various medications, the ones that you have to know. Please, let's know them. Please, what is the therapeutic index of digoxin? Hey, please, it is not 10 to 20, please. It is not 10 to 20. 10 more, 20 more. Toxicity. It differs from various reference range labs or reference books. Some resources will tell you 0.8 to 2, 0.8 to 2 nanogram per ml. Some books will tell you 0.5 to 2 nanogram per ml. But let's take note, if it goes above the 2, then we know that there is a possibility that the child would have what? The toxicity. So please, let's take note. So in that instance, we don't have to give the digoxin. We have to notify the healthcare provider. And please, lastly, which electrolyte imbalance? If it is low, which electrolytes? If it is very, very, very low, increases the digoxin toxicity. So if a patient is having that low in that electrolyte, it increases their risk of having the digoxin toxicity. Which electrolyte? Yes, potassium. So hypokalemia increases the risk of what? Digoxin toxicity. Hypokalemia increases the digoxin toxicity. So a child with tetralogy of Fallot, we may consider giving a child the digoxin just to increase the strength of the contraction. So please, we've come to the end of the Tetralogy of Fallot. So, and the last point that I would say is that we said earlier that the child should be fed small but frequently. So we can do a 3-hour schedule feeding, 3-hour schedule feeding for the child. 3 hours. We don't want a child to grow hungry so that they will cry. So 3-hour schedule feeding is very, very much important. And feeding the child as soon as they are awake or as soon as awakening from sleep. We don't want them to cry. So we feed them as soon as possible. And if you are feeding them, please, we feed them in a semi-upright position. Feeding them in a semi-upright position, very, very, very much important. And lastly, please, a child with the tetralogy of Fallot, and we are bottle feeding them, should we enlarge the hole in the nipple, or we should make the hole in the nipple small? What should we do? And why should we do that? Should the hole in the nipple be enlarged, or it should be made small? And why? Child with a tetralogy of Fallot. This is our last point. Should the hole in the nipple be enlarged, or it should be small? Okay, I'm seeing. Okay, RN. Okay, so the position again. Okay, so please, we are saying that if we are feeding them, we have to feed them in a semi-upright position. If you are feeding them, semi-upright position. Yeah. So please, should the hole be small or large? I'm seeing small, small. RN Vivian, please, why should the nipple of the bottle be small? RN Vivian, RN Salma, any one of us can unmute ourselves and talk. Why should the nipple of the bottle be small? RN Vivian Opoku, RN Salma, please, why should the nipple of the bottle be small? And RN Infinite Hot 10. Why should it? But please, any one of us can unmute ourselves and talk, please. Any one of us. Please, anyone. Please, any one of us can unmute ourselves and talk, please.
Right, so it should be enlarged to reduce the energy consumption or use while I'm trying to suck.
Exactly, boss. Exactly. Child with a tetralogy of Fallot, already they're having the hypoxia, the structural defect. So if you are doing more, or if you are using more energy, you need more oxygen. But in this case, they don't have that more oxygen in their system. So do we want to give them a bottle with a small nipple? If even as an adult, if you are taking a drink from a bottle and the nipple and the hole is very small, you see the kind of energy that you have to use to take that liquid from the bottle. We don't want that. So the hole in the nipple should be large enough. We should enlarge it so that they will use less energy while they are taking the food from the bottle. So please, I hope we all get it. Why we should enlarge the nipple of the bottle. So please, okay, yes. Okay, all right. Okay, so thank you very much. I think we have exhausted the 2 hours. So I think on Tetralogy of Fallot, the key NCLEX areas, let's know the structural defect, let's know the signs and symptoms, which is also very, very much important. Let's understand that it is a cyanotic defect, and also in terms of the diagnostic investigation, especially cardiac catheterization, let's take note of it. And the polycythemia aspects of the Tetralogy of Fallot, and also the positioning, the squatting, and the knee to chest, very, very much important. And also the nursing management, very, very much important. So please, any question, any contribution before we call it a day, please. Please, any contribution, any question before we call it a day? Aaron Adoma, Aaron Abba, Aaron Lily, please, all of us, any contribution before we call it today. Once again, assessments on Tetralogy of Fallot. All questions on Tetralogy of Fallot, and I think today we talked about the cardiac catheterization. So questions on Tetralogy of Fallot, cardiac catheterization. We put questions from different skill banks, and the assessments will be made available on the Telegram platform. So please, if you're not available on that platform, please, you can find a link and you join, and you have access to the questions. So
hello, sir.
Yes, boss.
Can I ask if we could have the reason of delayed closure in the still patent ductal arteriosus? That's why we give also the morphine sulfate, because if you remember, during in vitro, we wouldn't want to give morphine to or any opioid to the mother, because
Yes,
it has a potency of delaying the closure of the ductus arteriosus. So if we intend
those
want to give it,
NSAIDs,
NSAIDs, opioids.
Sure.
I mean, just a question anyway.
Okay, sure. So please, we are saying we spelled out why we want to give the morphine sulfate. So the morphine sulfate it's given to the child. So we give the morphine sulfate to the child, and the rationale for the morphine sulfate, the fact, so largely the medication that we want to avoid in pregnancy, those NSAIDs, it has an effect on the duct, the NSAIDs. That is especially if the child is in utero. So we would not even want to give the child indomethacin, because indomethacin would even cause the how do you call it, the closure of the duct. So over here, we want to give the child morphine sulfate. We are giving it to the child. The child is born. So the effects of the morphine sulfate, that is what we want. And we said that the morphine sulfate would decrease the anxiety. It will decrease, the child is having a TET SPELL. So if there is a way to decrease anxiety, it's good. So morphine sulfate is known to decrease the anxiety. It is known to calm the child down. If we calm the child down, clearly we will decrease the tachypnea. We will decrease the tachypnea. So that is why we want to give the child the morphine sulfate. Some resources will tell you one of the reasons is to decrease the pulmonary vascular resistance. The pulmonary vascular resistance. And it's one of the effects of the morphine sulfate. It decreases, it can decrease the pulmonary vascular resistance. That is why we give the child the morphine sulfate. But as I said earlier, we have to watch out, or we have to monitor the child for the side effects of the morphine, because we know that morphine can depress the respiratory centers. So if we give the morphine and if it depresses the respiratory centers, of course, the child would have very difficulty in breathing. So that is what we should monitor. But morphine sulfate is one of the first-line drugs that is given for a child with a Tetralogy of Fallot for these said reasons: decreasing anxiety, calming the child, decreasing the tachypnea, and also decreasing the pulmonary vascular resistance. So these are the reasons why we want to give the morphine. And you ask, why do we want to wait 4 to 6 months before we go in there to correct the defects? You realize that this is a serious condition. This is a serious condition. It's actually a complex condition for structural defects. So if we don't wait for this child to attain the adequate, or the what we call the ideal weight, the prognosis or the outcome of the surgery will not be too good, because having an ideal weight is very, very much important for these kids when they're going for surgery, because we are very much aware that some of this anesthetic agents that don't attain an ideal weight, it can have a whole lot of effect on you. Yeah, so the summary of why we wait is that we want the child to have an ideal weight, or to gain the ideal weight. So gaining the ideal weight goes in the large extent to decrease the complications as that may arise from the, how do you call it, from the repair or from the surgical procedure. So that is why the ideal weight is very, very, very much important. So that is that. I don't know whether further clarification is needed. So that is why we need to keep that ductus arteriosus open. We need to keep that ductus arteriosus open prior to the surgery. So it is just a palliative
I'm happy,
care.
boss. Thank you. I'm really happy.
Please, you're welcome, boss.
I
Okay,
was
please. So
also trying to ask if we give any pre-medication to those undergoing the the catheter
the cardiac catheterization.
cardiac catheterization. Yes, sure. And
Yes, please. Yes, please. Yes,
do
please.
we? Okay.
Yes, please. We talked about the pre-med. Sorry for cutting you. We talked about the pre-med that because we are going to use the contrast or the dye, some individuals would have a reaction. They will have an anaphylactic reaction, which could be very, very bad. So if the patient has a history of having this allergy before, and we talked about the cross allergy to the shellfish, which now is not an absolute contraindication. So if that allergy exists, then that is where we'll think of prednisolone or methylprednisolone, which can be given just to overcome or just to prevent those reactions. Because if the patient is going to have the reaction, it can be very lethal. So why don't we prevent it? So we can give the pre-med, we can give the prednisolone or the methylprednisolone to.
I meant with the bleeding, the possible bleeding.
Hello?
I meant with the possible bleeding. Yes, sorry.
Yes, exactly. Yeah. So if the patient stand at that huge risk of bleeding, or if the patient is bleeding, so we are very much aware the drug that we usually give when the patient bleeds. If the patient is bleeding after the procedure, the first thing that you have to do, you put pressure on the site because we need to stop the bleeding. But of course, we can give the patient tranexamic acid, right? So tranexamic acid can stop the bleeding. So we can think of medication that will stop the bleeding. And the common medication that will come to mind is our tranexamic acid that would help to stop the bleeding. But doing the non-pharmacological aspect too is also quite important. I don't know if I've answered the question.
Thank you.
Or if
Thank you. You have. Thank you so much.
Okay, boss. Thank you very much. Okay, so please, if there are no further additions, we want to end here and we do our assessment on the platform. So please, thanks a lot for your time. 2 hours, 23 minutes. It's not. We should not take it for lightly. You've done very, very, very well for joining us. Thank you, and we want to encourage each and every one of us that NCLEX is doable. In fact, NCLEX is doable. No, master your content, and you are just good to go. Do more content review. You are good to go. NCLEX is not difficult. It's not above any one of us here. It is not above any one of us here. But then it takes dedication. It takes hard work. It takes determination. If you're not determined, please, NCLEX is not for you. So please, let's take our review very, very, very serious. And on a light note, our March cohort starts very soon. So if you want to join the March cohort, as I said, we cover everything within the cohort, within a 4 months. Usually we don't admit new members once we start. So we mostly do fresh cohort, but as we start from the very fundamental, we start from the scratch, we build content from the scratch. We cover all the key and place areas. We don't give pre-recorded sessions. We go through everything with you and give you assessment from different skill banks as well. So please, thank you very much. We shall continue from here, God willing, next week. Thank you, and have a great evening.
Hello, sir. Hello.
Yes, boss.
Can I ask a quick question? So,
yes, boss. Sure.
When with the class, when is the ideal time for meetings?
Okay, please. Please, which one? This one that we are doing, the Achievers Friday. For the Achievers Friday, every Friday, 4 p.m. Ghana time.
Okay, not this one, but I mean the class that you've just shared on the screen.
Okay, please. So just something brief about the class. So with the class, for the first 2 months, we meet 3 times in a week. Okay. And 3 times in a week, the minimum meeting hours is 2.5 hours. And the minimum topics that we discuss is 3 topics within the set time. Okay. So the 3rd and the 4th month, we increase the days to 4 days. 4 times in a week, 4 days, the same number of hours. But most of our meetings is from 4 p.m. Ghana time to 6:30 Ghana time. This same time that we started the this very session. So that is the overview of it. So we go through everything. So after doing the topic per session. We put questions from different skill banks in the form of assessment, and you do it, you get your scores, you're able to remediate on the areas that we've discussed. And we also provide key NCLEX points on the various topics that we discussed as well. So that is basically the overview of our tuition.
Right. I'm more than happy to join, but it's just the timing, because from 4 to 6, I might not be at home. I'll be at work.
But one other thing is that we always make the recording available to our nurses. So the recording, if let's say you are late, we make the recording available on a platform so that you watch the record. So we are going to make this recording available on the Telegram platform as well, so that at least you can revisit it anytime that you want to. Yes,
right. I'm not sure I'm on the Telegram page, so I'll check.
Okay. Let me try and copy the link of the Telegram page here.
Super.
So that at least those of us who are not on the platform, so we'll be using the Telegram page. In fact, the Telegram platforms are 4. All the Telegram platforms are loaded with resources. Very, very loaded with resources. One of the Telegram platform, NCLEX documents, audio, thousands of resources, video, audios, PDF, a lot. So you may want to join those, and those are free platforms. But for our tuition, it's a paid tuition.
Right.
That is just.
No worries. How much is it? I don't
just
mind.
a quick one. Let me share.
Okay.
Oh, okay. So in Ghana cedis, it's 400 cedis a month in Ghana cedis. So if you are to convert it into US dollars, so that would be $32 US. If you are to convert it into Nigeria naira, that would be around 50,968 naira. Yes. So you can use the standard. You can use the 32 USD to do the conversion from the country that's
right. Okay.
That you are.
Okay.
Sure.
Hello,
okay,
Aaron.
Thank you very much.
Hello, Aaron.
Thank you.
Yes, please.
Hello.
Yes, please, Aaron Aduma. Please, we are here. Please, we are here, Aaron Aduma.
Yeah, hello, Aaron. Yes, I'm pleased to as our brother was saying, if you are not available after the recording, we have various mentors, we have various people that in case you encounter any difficulty or you are not clear with anything about the recording, you can just contact. We have people around, you can just contact for clarification as well. And please, we will also entreat you all to also share the Achievers Friday link so that your colleagues, other colleagues too, can join.
Right.
Thank
you. I will. Thank you.
Okay, please. Thank you very much. Please, the links have been shared in the chat box. So please, we can copy the link now before I end the meeting.
Okay.
Thank you very much for joining. Have a great evening.
Have a great evening, sir. Thank you.
You're welcome, please.